Hello, my name is Aspen Alou, and today I am presenting my literature review on hormone replacement therapy as a prevention strategy for type 2 diabetes in women. This topic is particularly relevant because menopausal women face a dramatically increased risk of developing type 2 diabetes, and emerging evidence suggests that hormone replacement therapy may offer significant protective benefits beyond just treating menopausal symptoms. My presentation will cover the evidence base for this approach, key findings from recent research, and practical implications for healthcare practice, all integrated with biblical principles of health stewardship. Let me start by framing the problem and research question. Our problem statement is the following. Menopausal women experience dramatic hormonal changes that significantly affect their glucose metabolism and insulin sensitivity. When estrogen levels drop during menopause, women face increased visceral fat accumulation, reduced insulin function, and deteriorating metabolic parameters, all of which substantially increase their risk of developing type 2 diabetes. My PICO question. My research question uses the PICO framework. Population, which is peri- and postmenopausal women at high risk for type 2 diabetes. Our intervention will be hormone replacement therapy, including estrogen, progesterone, and/or testosterone. Comparison, placebo or standard diabetes prevention care. And our outcome is reducing diabetes incidence and improving metabolic parameters. The time will be over 12 to 24 months. The essential question is, can HRT effectively prevent or delay diabetes development in this vulnerable population? For our search methodology, I conducted my literature search using multiple databases, including EBSCO, CNOW, PubMed and Medline, and the Cochrane database, focusing on peer-reviewed research from 2021 to 2025 to ensure the most current evidence. Now let me share the foundation of evidence supporting this review. Research quality. My review synthesized multiple levels of evidence. Level 1 evidence from systematic reviews and meta-analyses. This represents the highest quality evidence, synthesizing multiple randomized control trials. Level 3 evidence from large-scale cohort studies providing real-world data. Clinical practice guidelines from leading organizations like the North American Menopause Society. The scale of evidence. The scope of this research is substantial, over 1.2 million participants across all reviewed studies. This gives us confidence in the findings and their applicability to diverse populations. Some of the key studies include 4 landmark studies which form the core of this review. Gartler-Herner and colleagues 2022 systematic review for the U.S. Preventative Services Task Force. Spence-Snyder's 2023 meta-analysis examining glucose regulation effects. She's 2024 retrospective cohort study following women for 20 years. And Yuk Kim's 2023 analysis of over 1 million women in South Korea. Now I'd like to discuss the first major theme, the metabolic benefits of hormone replacement therapy. Glycemic control improvements. Research demonstrates that HRT produces clinically meaningful improvements in blood sugar control, specifically hemoglobin A1C, which measures average blood sugar over 3 months. This decreased by 0.4 to 0.8%. To put this in perspective, this reduction is comparable to what we see with some diabetes medications like metformin. Fasting glucose levels also improve significantly, dropping by 1 to 2 millimoles per liter. Mechanisms of action include, these benefits aren't superficial, they work at the cellular level. Estrogen enhances insulin sensitivity, meaning that the cells respond better to insulin and can take up glucose more effectively. HRT also reduces visceral fat accumulation. the dangerous fat around internal organs that's strongly linked to diabetes risk and heart disease. Dual benefit. What makes this particularly valuable is that HRT addresses the root metabolic dysfunction caused by estrogen deficiency rather than just treating symptoms. Women receiving HRT for menopausal symptom relief simultaneously gain metabolic protection. These findings come from Speck-Snyder's rigorous meta-analysis of 19 randomized controlled trials involving 1,412 participants, which provides a robust, high-quality level of evidence. Moving to theme 2, how effective is HRT at actually preventing diabetes? Long-term protection. The most striking finding comes from Xi's 20-year cohort study, which showed a 31% reduction in diabetes incidence among HRT users compared to non-users. This isn't just a short-term effect. This protection persisted for 2 decades, suggesting HRT creates lasting metabolic changes rather than simply delaying diabetes onset. Additional range of benefits. Across all studies, risk reduction ranged from 12 to 31%. This variation reflects different populations, HRT formulations, and study designs, but consistently shows meaningful protection. The optimal candidates. The research identified specific groups who benefit most. Women aged 46 to 50 years and 55 to 60 years. These age ranges represent the early menopausal transition when intervention is most effective. Women with a BMI under 30, suggesting HRT works best before obesity becomes established. Women in early menopausal transition, timing matters significantly. Population impact. Gartler-Henner's study data shows that for every 10,000 women treated, we prevent 78 to 134 cases of diabetes. When you consider how many women go through menopause, this represents a substantial public health benefit. Theme 3 addresses a critical question. When and for whom should we consider HRT for diabetes prevention? The window of opportunity. Research has identified what's called a window of opportunity for HRT initiation. This concept is crucial. HRT provides maximum benefit with minimal risk when started during the early menopausal transition, not years after menopause. Additionally, in women under age 60 and in women without existing cardiovascular disease. This timing window exists because estrogen receptors and cardiovascular health are better preserved in younger, recently menopausal women. Starting HRT later may not provide the same benefits and could possibly increase risks. Individualized assessment. Before initiating HRT, healthcare providers must conduct a comprehensive cardiovascular risk assessment. The research by Pascu and colleagues emphasizes using validated electronic algorithms that incorporate patient age, menopausal status, and cardiovascular risk factors. This ensures we're identifying appropriate candidates who will benefit from therapy while avoiding those who might face unacceptable risks. Clinical implications. This means HRT for diabetes prevention isn't appropriate for all women. It requires careful patient selection based on individual risk profiles and timing relative to menopause onset. Now let's address the theme 4, the critical balance of benefits and risks. Benefits. The benefits are multifaceted. Diabetes prevention, as we've discussed, improved overall metabolic health, relief from debilitating menopausal symptoms like hot flashes and night sweats, bone health protection, reducing fracture risk, cardiovascular benefits in appropriate selected younger women. Risks to consider. HRT isn't without risks. Possibilities include venous thromboembolism, which is blood clots in veins, stroke risk, which increases with age, possible gallbladder disease, and urinary incontinence. These risks vary based on formulation, dose, route of administration, and individual patient factors. For example, transdermal estrogen carries lower clot risk than oral formulations. Key prescribing principle. This leads to an important clinical principle. HRT should be prescribed for established indications, primarily vasomotor symptoms that significantly impact quality of life. Diabetes prevention becomes a valuable additional benefit rather than the sole reason for prescribing. I would not recommend starting HRT solely for diabetes prevention in asymptomatic women, but for women who need HRT anyway for symptom management, the diabetes prevention benefit makes the risk-benefit ratio even more favorable. I'd like to discuss how these findings should change clinical practice. Metabolic screening protocols. Healthcare organizations and providers should implement routine metabolic screening during menopausal care visits. This means checking hemoglobin A1C, fasting glucose, or performing a glucose tolerance test for perimenopausal women, especially those with risk factors like family history, obesity, or metabolic syndrome. Early identification of prediabetes creates opportunities for intervention during the optimal window. Standardized risk assessment. We need validated cardiovascular risk assessment tools integrated into clinical workflows. These decision support systems help providers quickly and accurately evaluate which patients are good HRT candidates and which should pursue alternative approaches. Provider education. Medical staff need updated education about modern HRT formulations. Yukon Kim's research showed that contemporary HRT preparations have different metabolic effects than older formulations used in studies from the 1990s and early 2000s. Providers must understand these differences to counsel patients accurately. Patient education. Women need comprehensive, balanced information about both symptom management and metabolic benefits. This supports informed decision-making where patients understand the full range of potential benefits and risks. Shared decision-making. All of this supports robust shared decision-making frameworks where providers and patients together evaluate individual circumstances, preferences, and values to determine the best approach. I'd like to connect these findings to principles of stewardship from the Bible. 1 Corinthians 6:19 through 20 teaches that our bodies are temples of the Holy Spirit and we should honor God with our bodies. This theological truth has practical implications. We have a responsibility to care for our physical health as an act of worship and stewardship. Evidence-based preventative care, like appropriately using HRT to prevent diabetes, aligns with this biblical mandate to honor God through responsible health management. I'd like to conclude by directly answering questions and to provide some recommendations. How does HRT compare to traditional diabetes prevention approaches like lifestyle modification programs? HRT offers a unique dual benefit that traditional approaches don't provide. It simultaneously treats debilitating menopausal symptoms while providing metabolic protection. For a woman suffering from severe hot flashes, HRT addresses her immediate quality of life concerns while also reducing a risk of diabetes. HRT is more comprehensive than lifestyle modifications alone because it addresses the hormonal root cause of metabolic dysfunction. In the future, we need more research on personalized risk assessment tools to better identify which women will benefit most from HRT. We also need optimized treatment protocols and ideal formulations. Hormone replacement therapy represents an evidence-based prevention strategy that, when used appropriately in carefully selected patients, can significantly reduce the burden of type 2 diabetes in menopausal women while addressing their immediate symptom needs. Thank you for watching this presentation.